Hello everyone, I'm Andrey Soares. I'm a medical oncologist in Brazil. I'm here with Tom Powles. Tom Powles is a medical oncologist, director of Bart Cancer Center in UK, and host of the Ura Amigos podcast, one of the best podcasts in Euro oncology team. So we are here at Madri, having a very nice meeting, mainly in GU tumors. And yesterday we have a presentation of two very important trials in M urothelial carcinoma patients. So just to put in the context, we stay like for almost 30 years with only one data showing that since the cisplatin-based chemotherapy show a benefit regarding of OS, PFS, and overall response rate over a cisplatin monotherapy, only in 2020 we have the data from Javelin bladder showing that chemotherapy followed by a switch maintenance with avelumab, we gain overall survival and control of the disease of these patients. So, but this is not the best what we are pursuing for these patients. And we are pursuing to some kind of therapy to replace chemotherapy. So what we have yesterday here at the presidential session with you and the GC NIVO trials, what you can say to us about this data?
Well, thank you for inviting me, firstly. And I think the unfortunate vedotin pembrolizumab combination we felt was very active. Both monotherapy, single agents, we now have activity. But what was, in my opinion, what was surprising is when we saw those first phase 2 data, which showed response rates of about 70%. Because in the past, when we've combined drugs together in urothelial cancer, we've never really had that additive effect. And the randomized phase 3, the 302 trial, was really designed to test that in a big randomized phase 3 against GemCis and GemCarbo. And as you said, we've never beaten GemCis or GemCarbo in the frontline setting in unselected first-line metastatic disease. It was an 850 patient trial. A big randomized phase 3. It was done in 200 sites, and what we showed was that about half the patients had cisplatin in the control arm. About 30% of the patients in the control arm got maintenance of avelumab, and we showed a progression-free survival advantage with a 55% reduction in the risk of progression, which we've not seen before, and that was across broad subgroups of patients irrespective of PD-L1 status and platinum eligibility. But what was really remarkable was the survival advantage, and we showed a 53% reduction in the risk of death compared to chemotherapy. It's very unusual in cancer trials to, frontline setting in top 10 cancer to reduce the risk of death by more than 50%. We showed about a 30% CR rate, and again, we've not seen that. And those patients that responded, 68%, we've not reached the median time progression. I've got patients in my centre who are on the combination who continue to respond years down the line. This is very different from the cisplatin experience. And when you look at the toxicity of the two agents, you can see grade 3 or 4 adverse events of 70% of the chemotherapy and 56% of the unfortunate vedotin pembrolizumab arm. Adverse events of special interest, skin toxicity, occurred in about 15% of patients grade 3 or more, but there were no skin toxic deaths, which I think is important, and really important educational point. If you get skin toxicity, stop the drug, let it resolve. Peripheral neuropathy, again, if you're developing peripheral neuropathy, it tends to turn later, and that's in about 10% of patients. But you don't have to get peripheral neuropathy. You can stop the drug, and it doesn't. So it's like cisplatin. You can treat. You get it if you treat through it. So let's not do that. So there's education training around the toxicity profile, which I think is important. We showed benefits from the survival across all the subgroups of patients, irrespective of platinum therapy, visceral metastasis, PD-L1 status. So this is the first time we've beaten first-line chemotherapy. We've not done that before. I've tried many times, and none of those have been successful. And so this was very remarkable. And I think it is a new global standard of care. I think the results are transformative. I don't think platinum eligibility is such a big issue anymore. I think that most patients are eligible for unfortunate vedotin and pembrolizumab. That should be the first question that you ask. And and the vast majority of patients, I think, should get the combination, and I think they'll benefit from it.
It was very interesting because it's very, very hard to see, an overall survival advantage with a hazard ratio lower than 0.5. It's incredible. It's incredible data. And after the presentation, we have the presentation of Checkmate 901. That's a quite similar trial, looking at the Gen Cs versus Gen Cs Nivo. This is a difference. I think that's the main difference. Only patients cisplatin eligible.
Yes.
And what we saw in the data is the benefit in PFS, benefit in OS,
yes,
and benefit in overall response rate,
yes,
favoring the combination, the GC plus nivolumab. But the magnitude of the data, it's not the same. The overall survival is around 0.7,
yes,
favoring the combination
yes,
over the standard treatment. What is very interesting, when we see the curves,
yes,
so I said that the demographic is quite similar,
yes,
outside the cisplatin eligibility, yes, but the other characteristics are quite similar.
Yes.
And when we see the data of chemo arms in both trials, you can see that the curves of PFS, OS, and overall response rates is really, really similar between
Yes.
both. But the difference is in the combination of the trials or pembro EV. What do you think that did this huge magnitude of the benefit of pembro EV versus GC Nivo?
Yeah.
It is the backbone drug. It's the difference between the immune checkpoint inhibitors.
Yeah. So I think firstly, Michael did a fabulous job presenting that data, and congratulations to the BMS team for conducting an excellent trial. We did 2 previous trials, 130 and 361, with chemotherapy, including cisplatin, plus either atezolizumab or pembrolizumab, and we didn't show that survival advantage. We showed a PFS, but not an OS in 130 in the atezolizumab trial. But we did show a trend towards an advantage in those trials. And in some of the subsets, cisplatin looked promising, and one of the trials it didn't look promising from a survival perspective. A lot of the benefit inevitably is going to come from that maintenance period. We talked about maintenance of avelumab at the beginning. The hazard ratio is 0.78. Probably about 10% of that is driven by maintenance of avelumab. Some people might say more, but that will drift things down closer to 1, maybe 0.88, maybe 0.9. But there is an important. So some people say, well, isn't this just maintenance of avelumab? Do you need to give it during the first period? The hazard ratios are similar to the Javelin hazard ratio, but there are subtlety differences. The Javelin hazard ratio only starts at the completion of chemotherapy, and that's important. So although it's 0.70 or 0.75, and so the number's lower, it's only for half of the patients, and it only starts once the chemotherapy is finished. And I think that we showed a higher CR rate with chemo and nivo, and those responses were durable. And so I think it's fair to say at the moment that in this cisplatin eligible population, the results of 901 were consistent with the previous trials. This was a positive study. Those previous studies were marginally negative. And so it's not a black swan event in that respect. It's not totally unexpected. Congratulations to the team for conducting an excellent trial. I think that some of the benefit comes from the avelumab period, but from a patient's perspective, they might say, well, hold on a second. I don't want to wait to start the immune therapy. I can wait, but I don't want to wait to start. I want to because I might not get the immune therapy. I want to start now. I want to start front. And I can see why patients would be attracted to that. Do I think there are huge advantages of cisplatin and nivo compared to maintenance of avelumab? No, they're not. They're not the transformative advantages we saw with unfortunate vedotin and pembrolizumab. But can I see doctors and patients saying, well, I'm cisplatin eligible. This trial, I get that from the start, there's a survival advantage. I don't want to wait. I can see that happening. I can also see payers saying, look, I'm not sure I want to pay for that bit up front. The avelumab looks cost effective, and there's not a huge difference between the two. The control arm wasn't avelumab, so it's not been beaten yet. And I can see people saying, well, it's better value for money to wait, and I can see that too. So I think, if it wasn't for the EV Pembro data, I think we'd be having a very hot debate now about whether you need to give nivolumab up front or whether actually it's okay to wait. As I said before, that CR rate looks promising. But because of the EV Pembro data, I think it makes that debate less relevant for those patients who are eligible for unfortunate vedotin and pembrolizumab, which is the vast majority of urothelial cancer patients.
Maybe you are seeing like a synergistic effect between pembro EV that we cannot see with immune checkpoint inhibitor with chemotherapy.
I think it's a more positive effect.
Yeah, positive.
I think chemotherapy and immune therapy. I think in bladder cancer there is some antagonism there. You know, in the original study with atezolizumab, it was 45% response rate for chemo, 20 for immune therapy, and only 47 for the combination. So you were losing 13% of those immune responders. So I think that there is some antagonism. And I think that's partially true for Pembro, and I think that, whether or not EV Pembro is synergistic or just genuinely additive, or whether there's something along the, and Andrey Apollo explained the biology beautifully actually, whether there's something around the long-term biology associated with MMAE and the payload that makes a positive or synergistic interaction. I think that's something we need to talk about, but I think it is at least additive, and I think chemotherapy and immune therapy hasn't achieved that.
When we see the data from mVigor 130,
Yes.
there's a biomarker analysis showing that maybe the patient with more inflamed tumor
Yes.
has a detrimental effect when
Yes.
adding the chemo. So this is very interesting. And this we can see it's reflecting in duration of response. When you take a look in the duration of response of the Checkmate 901, it's only 9.5 months against 7.3, I think, in the chemo arm. When you look in the EV trial, it's not reached with the lower boundary, 20 months. You know, it's amazing. So my last question, or my last topic to discuss with you.
Coming back to that duration of response issue,
great.
I've got those patients in my clinic who are wandering around, having normal lives, going to family events, 2 years down the line, having had these dramatic responses. And I've spoken to my friends and colleagues who enrolled large numbers of patients in this trial, and they've got the same thing. We didn't know the trial was going to be positive. We had so many negative trials. I was having sleepless nights because I just thought, oh no, surely this one's not going to go wrong. But the reality is that when you speak to your friends, with all who took part in the trial, we all have these patients who, historically wouldn't have done as well as this. And this is why I think we all felt it was going to be a positive trial.
That's nice. But looking at the toxicity, we said that the population is almost the same. Probably the population in the GC91 would be better because it's only patients eligible to cisplatin. But when you take a look for the patients with toxicity, we saw more toxicity in patients receiving chemotherapy in the EV arm. It's 70%. When we take a look in patients in GC, it's only 50%.
Yeah.
I'm talking about grade 3 to 4. Yeah. And mainly in myelosuppression. Yeah. Why this difference between the trials? This difference of toxicity, and if you can say something about the discontinuation due to toxicity, both drugs, one or other drug.
So
it wasn't clear yesterday.
Well, it wasn't clear because my talk was so haphazard. I lost my concentration when people started clapping, and it got worse and worse. And the less said about the end, the better. But no, it was very flattering and transformative, and I think that's
Definitely.
why the audience was so positive around it.
Everyone was emotional yesterday.
Well, we have spent 40 years trying to beat first line, and we've had dozens of trials and tens of thousands of patients taking part in those studies, which all in the end haven't made a huge difference. And so to have this transformative result, I think it is emotional for the field because we've watched other cancers change. How many times have we watched a new lung cancer drug, a new presidential session, a new ALK inhibitor, a new breast cancer targeted therapy, the breast cancer team being ADCs for 10 years, and suddenly we managed to achieve an important goal.
I was sitting with Henrique Gant yesterday. He was so excited with the data, He was really, really happy.
We'll talk about toxicity. I apologise. I get distracted. I apologise. So, I think you're absolutely right. I think although the toxicity does numerically look higher with cisplatin-based chemotherapy or platinum-based chemotherapy, I think both regimes are associated with significant treatment-related toxicity, and the grade 3 or 4 adverse events are above 50% in both arms, and they require really careful attention. Unfortunately, vedotin is the skin toxicity. If you get skin toxicity in the first month, you really do need to stop the drug and reconsider dose reduce. If you treat through skin toxicity, you get into trouble, and we had that experience early in the program. It's all about education and training. And then the second piece is around peripheral neuropathy. You really do, if you're getting peripheral neuropathy, it's both motor and sensory. And if you're getting peripheral neuropathy, hold back on the drug, let it recover, and then start a lower dose. And those two pieces are really important. and monitoring for hyperglycemia is also relevant. There are other pieces. There's some fatigue, obviously, and there's immune-related toxicity, which is in line with expectations. But overall, the pattern is one of all of these regimes are difficult to give. Cisplatin is difficult to give. You know, would never. If cisplatin was discovered tomorrow, I wonder if it would be developed. Because, you know, the nephrotoxicity, you have to give fluids for 4 hours beforehand, really bad nausea and vomiting, and of course the myelosuppression and neutropenic sepsis. So these drugs are challenging. This is not like hormone therapy with prostate cancer. But the terrific news is that with education and training, we can give in EV pembro safely.
Last quick question. Do you think that this kind of toxicity, mainly neuropathy, we can discuss about the sequencing? So, okay, I start with GEM-Cs, that's 4 to 6 cycles, and then the patient has not so many neuropathy, and then I can give EV in a third line, you know, if you do like switch maintenance for this kind of patients. Because some people can say, like, if the patient receive pembro EV and develop a neuropathy, I can give, you know, Gen Platinum after that. So you think that the data is very compelling, eh?
So I think the answer to the question is, in urothelial cancer, one of the things that's very apparent to me is most patients don't get to second, third and fourth line therapy. And those patients that do, don't do terribly well with it. I think you get one really good go at treating urothelial cancer, and I think the unfortunate vedotin pembrolizumab data was really compelling. And so where I currently stand with this, drug availability aside, is if you're going to do this, I would give them unfortunate vedotin and pembrolizumab and try and hopefully be one of those patients that goes into a long-term durable remission, which I have many of in my practice.
Tom, very much to be here with us. Thank you very much. Just remember, in Brazil, we will have the approval of pembro EV probably very soon in patients ineligible to cisplatin, based on the previous data, not the phase 3 data, but in patients ineligible to carboplatin. So we are very happy to do this in Brazil too. Thank you very much, Tom.
Looking forward to seeing you in Brazil very soon.
Yeah, I hope
Thank
to.
you.
Bye.